talk about the disorders of secondary hemostasis, and in this first we're going to talk about hemophilia. So for hemophilias, first these are the factors, all the factors. We have factor 1, that is fibrinogen, prothrombin, 3 is tissue factor, 4 is calcium, 5 is proacceleratin, 6 does not exist, okay, it is nothing. And then 7 is proconvertin, 8 is antihemophilic factor A, 9th is hemophilic factor B or Christmas factor, X is Stewart power factor, and 9 is antecedent of plasma thromboplastin, 12 is Hagman factor, and 13 is fibrin stabilizing factor. You need to remember antihemophilic factor A and the Christmas factor. That is hemophilia A, and this causes hemophilia B. So where is going to be the problem? This is the coagulation cascade right here. The problem lies in factor 8A and the factor 9A, right? Okay. Then we have right here, the problem is in secondary hemostasis. So we are going to have abnormal prothrombin time and abnormal APTT. The problem is in secondary hemostasis, we're going to have deep tissue bleeding, hemarthrosis, rebleeding after surgery, and cranial bleed in severe cases. Then next disease we have is von Willebrand disease. It is basically the deficiency of von Willebrand factor, and this disease is the only disease that is both quantitative and qualitative. Where is the problem? In qualitative, we have the von Willebrand factor. If this is deficient, there is going to be abnormal platelet adhesion. And in coagulation cascade, factor 8 requires von Willebrand factor to stabilization, because without von Willebrand factor, factor 8A is going to degrade, or it's unstable. So it's both primary and secondary. So you're going to have both deep tissue bleeding, hemarthrosis, rebleeding, and cranial bleed, and plus skin and mucosal bleeding. Right here, it has problems with both primary and secondary hemostasis. So the platelet count is going to decrease, bleeding time is going to increase, APTT and NPT are both going to be abnormal. Plus, we're going to have decreased factor 8 in the blood, and there's going to be abnormal ristocetin test. So basically what ristocetin does is that it binds VWF to GP1B. That is going to cause platelet agglutination. But because we do not have, we have deficiency of von Willebrand factor, so ristocetin cannot bind to GP1B, and there is going to be no platelet agglutination, and hence abnormal ristocetin test. What is going to be the treatment? The treatment is desmopressin, which is basically an ADH analog, and this causes increase the release of von Willebrand factor from Weber-Palat bodies. And that is it. As easy as it is.